In this video, we will be reviewing the laboratory tests and imaging studies required for assessment of the severity of disease and for the diagnosis of COVID-19. Laboratory findings are nonspecific. However, I have found three values to be particularly helpful in assessing the severity and prognosis of COVID-19. C-reactive protein, abbreviated CRP, is a measure of the degree of inflammation and is elevated in the majority of cases. A normal value is 0 to 5. More severe cases of COVID-19 have levels of 100 to 400, and the higher the CRP, the higher the likelihood of severe disease. High levels also signal the development of a cytokine storm, but more about this a little later. D-dimer is a reflection of abnormal clotting and is elevated in severe cases. A normal value is less than 0.5. A value of 1 to 2.5 is associated with approximately a threefold increase in clot formation in the veins or arteries, and a value of greater than 2.5 is associated with a 6 to 7-fold increased risk of abnormal clotting. The lymphocyte count has been shown to be an important prognostic factor. When it is under 800 or 0.8 thousand, the risk of poor outcome increases. Here are the values for the patient I presented. Note the marked elevation of CRP, D-dimer, and the decrease in lymphocyte count. Note how these parameters all improved after convalescent plasma was administered. At the time of the plasma administration, the lymphocyte count had dropped to 0.48, subsequently rising to a normal value of 1.16. Here are two of our patients' x-rays on day 1 and day 2. You can see the marked increase in lung opacification or whiteout consistent with the development of acute respiratory distress syndrome or ARDS. Chest x-ray is abnormal in 60% of patients. Chest CT is a more sensitive, identifying abnormalities in 84% of cases. It should be emphasized the CT scan may identify abnormalities even in mild cases. In severe disease, 96% of the time, abnormalities are identified. Here are two examples of a ground glass appearance on the left is in one lung field, the arrow. On the right is bilateral ground glass appearance. Diagnosis is made by a polymerase chain reaction of a swab coming from the posterior pharynx or throat. This test is highly specific, 98 to 99% specificity. The sensitivity is difficult to estimate because the sensitivity depends on the sampling method. The best PCR test can detect as few as 10 copies of the virus. However, because of sampling, the sensitivity is only 70 to 80%. What that means is if you have a positive test, that is a true positive. However, negative test, 20 to 30% of the time, it's a false negative. Originally, many countries had a shortage of tests, including the US. Now, with improved availability, many health systems are screening all patients admitted to the hospital to exclude asymptomatic carriers. Aggressive testing, combined with contact tracing and isolation, are the ideal approach for controlling an outbreak once the number of daily cases becomes manageable. This was the approach used by South Korea, and as I showed in the epidemiology video, South Korea's epidemic curve has dramatically flattened. As of March 17th, South Korea, population 51 million, had performed 274,000 tests, as compared to the U.S., population 327 million, who had performed 25,000 tests. To achieve the same per capita testing, the U.S. should have performed 1.75 million tests. No wonder we have been so slow in bending the epidemic curve in the U.S. Recently, testing has dramatically increased in many states in the United States, and these states now many aspire to apply South Korea's approach to keep the U.S. to an R sub 0 below 1. A word about antibody testing. On this graph, the vertical axis shows the level of IgG and the horizontal axis time from onset of disease. The blue line shows the time course of the rise of antibodies in a non-critical case, and the green line, the rise in antibody levels in a critical case. Because IgG and IgM antibodies usually take 7 to 14 days to rise, as shown here, this test is not recommended for diagnosis. At the present time, it is recommended primarily to be used in epidemiologic studies to measure prevalence of disease. To summarize the content of this video, laboratory findings are non-specific. However, 3 values are particularly useful for assessing severity of disease and likely outcome or prognosis. They are CRP, D-dimer, and absolute lymphocyte count. Chest X-ray shows infiltrates 60% of the time, while chest CT demonstrates abnormalities in 84% of cases and 93% of more severe cases. The classic finding being a ground glass appearance on CT scan. Diagnosis is made by RTPCR. This test is highly specific because of sampling issues, has a low sensitivity of 70 to 80%. We need to test aggressively in order to identify the large number of asymptomatic carriers. Immunoglobulin tests is presently only recommended for epidemiologic studies of prevalence of disease.